Hi, everybody. I think we're going to get started because we have a few minutes of introduction and we have a lot to cover. So first of all, thank you to everyone for joining us today. This is might be our first ever, I'm not sure, but or it's our first in a while, joint meeting webinar between the NYACP and NIMDA. Today's presentation is titled Home and Skilled Nursing Facility, Post-Operative Care of Older Adults, presented by Dr. Donna Seminara. I'm Dr. Paula Lester. I am the Vice President of NYMDA and the Chair of the Geriatric Task Force of NYACP. So I'm here wearing two hats, both of which are invisible, but you can imagine them. And I want to speak to you a little bit about each of the organizations. So disclosure, the planning committee was me, and I have no financial conflicts. The speaker today is Dr. Donna Seminara. She also has no financial conflicts. I will take this opportunity to tell you that Dr. Seminara is a geriatrician in private practice on Staten Island with over 25 years of clinical experience. She's the director of the Division of Geriatrics at Staten Island University Hospital of Northwell Health, where her responsibilities include coverage of geriatric ambulatory clinics and serving as the medical director of the home visit program, which cares for over 400 community homebound older adults. She also serves as the medical director of Eager Healthcare and Rehab Center, where she supervises a medical team of 9 physicians and assists in the design of medical policy to provide care to over 300 vulnerable elderly residents. I won't say when, but many years ago, I did one of my rotations at Staten Island University Hospital, and I remember being in awe of the Geri fellow and how she just like knew everything, and that really cemented my interest in geriatrics. So thank you for that. This is a list of people, and my screen is blocking the top. This is the disclosure for the member of the college's Education Content Validation Committee. For this meeting, CME will be available, and we thank the NYACP for supporting and providing that. So in order to get your CME credit, you actually we will send out a link after the meeting and on a chat. But basically, you can go to the NYAC webpage and then follow the links, and this is the direct link that we will send that to you. I just want to share a little bit because we have some people here who are members of NYACP and some people here who are members of NIMDA and some people who are members of neither. And so I want to make sure that you know about the great opportunities provided by each organization. So NYACP is the state chapter of the American College of Physicians, serving internists and the subspecialties within internal medicine. It is New York State's largest medical specialty organization. Being a member of NYACP provides opportunities to meet with and collaborate with other physicians, to showcase your academic work, to learn from experts in the state, and to access numerous resources. So check out the webpage. And there are opportunities to get involved with chapter committees and task forces and to advocate at the state level and leadership within NYACP. And so it's really a wonderful resource full of great people. So please keep that in mind for any internist or subspecialty within internal medicine. NIMDA is the state chapter of what used to be called AMDA, the American Medical Directors Association. It was renamed the Society for Post-Acute and Long-Term Care because it's not just medical directors, it's for really any providers in post-acute or subacute and long-term care, but they haven't figured out a good acronym for Society for Post-Acute and Long-Term Care, so they still say AMDA. And so it serves medical directors, attending physicians, nurse practitioners, PAs, and others providing care in long-term care and subacute rehab, dedicated to excellence in patient care and education, adequacy, information, and professional development. So NIMDA also provides CME webinars and also CMD for those of you who are certified medical directors. And NIMDA has full-day symposiums, similar to how NYACP has full-day conferences. And NIMDA works with governmental agencies to work on making the regulations and surveillance meaningful and useful. So you can find out more about NIMDA at nimda.org. You can find out more at NYACP at nyacp.org. And so thank you again for joining us. So both ACP and NIMDA have additional information, online resources, and future events. So keep these web pages in mind. And with that, I will stop sharing and allow Dr. Seminara to start. I will share with you that this is an open, I don't want to say the right word. This is a meetings format. So if you're unmuted and your dog starts barking, we will all hear that. We encourage you to stay muted. And if you have any questions that you don't feel you can wait for, you can send them through the chat. Otherwise, at the end of the session, then Dr. Seminara will take questions, verbally or through chat. And so again, thank you so much for being here.
Thank you so much, Paula. I really appreciate that. I just want to thank again the leadership of the New York chapter of the American College of Physicians and NYMDA for the opportunity to talk today on a subject which I think has a lot of bearing in continuity of care in geriatrics. My experience working in the hospital, working in a nursing home, in private practice, ambulatory clinics, and in home visit programs really gives me a 360-degree view of the geriatric patient. And I really see that the transitions of care are key to maintaining people in their best environments, and the environments which are going to allow them to do their best in terms of recovery. So I want to just, again, thank you all for this opportunity. So as an overview, we're going to be sort of stratifying post-operative care, looking at factors that affect rehabilitation, such as medical comorbidities, geriatric syndromes, and looking at some of the economic and social challenges that are often unmasked, especially during times when there are acute surgical emergencies. We're going to look at the factors that optimize surgical recovery at home, and then take a deeper dive into the skilled nursing facility post-operative care arena, looking at how one chooses the right skilled nursing facility for this type of care, how to enhance communication with hospitals, and specific specialty care considerations. And with then a real look at telehealth and how telehealth has really changed communication between hospital-based practitioners and nursing home practitioners. So just to start, surgically, we know that there are over 1 million major surgeries performed annually in the United States in those over the age of 65. The majority of these procedures, however, occur within 1 year at the end of life. And for those procedures that are elective, about 18% of those are orthopedic, 12% are ocular, 10% abdominal, 9% cosmetic, and about 7% podiatric. The top numbers of surgical procedures, number one is angioplasty, followed by total knee replacements, then total hip replacements, and laparoscopic cholecystectomies. Retrospective evaluations of the rates of hospital admissions and complications of geriatric patients who undergo ambulatory surgery in the United States really stratifies over age. There are those over the age of 80, then those 65 to 79, and then those less than 65. And when you compare them, the oldest have the highest rate of same-day admissions to hospitals, highest rate of 30-day mortality, highest rate of post-operative complications, and highest rates of readmissions into the hospital. We really need to understand that there is something that can help us to recognize the patients who are going to be at greatest risk, and that is frailty. It is really the ominous geriatric marker. It's independently will predict post-operative complications, the length of stay that a patient will have, their discharge to a skilled or assisted living facility in older surgical patients. And it will, by assessing it, you can tell patients who are going to do more poorly. And with this recognition, it's really important to have an honest conversation with family members about the likelihood of having a smooth transition back to home. It is the factor that preeminently determines where a post-operative patient is going to recover. So the stratification of post-operative care in geriatric patients is, are they going to remain in the hospital? Will they recover at home? Or are they going to be best served by restorative rehabilitation in a skilled nursing facility? There are specific criteria for inpatient rehabilitation, that is, staying in an acute care hospital. First off, their acute hospital care needs may have resolved, or they can be managed between transport between the acute hospital and the rehab units. These units may be in the same building or in adjacent buildings on the same campus. The patient must be able to participate fully physically and emotionally, meaning that they're motivated, that they are anxious and ready to do the work of physical therapy. Their mental status has to be intact enough to be able to participate. So you will see patients who have diagnoses of mild cognitive impairment and or dementia, but these are patients, if they're rehabilitating in the hospital, that can follow commands and follow them reliably. If they do not possess that capability, it's unlikely that they will be cared for in an acute hospital setting. Inpatient rehab is the most intense. Therapy will be conducted for at least 3 hours per day over 5 days a week, or 15 hours over 7 consecutive days. Now, often, most commonly, these sessions will be broken out into 1.5-hour sessions. So a patient may participate in physical therapy in the morning, occupational in the afternoon. The next day have occupational and speech in restoration after a stroke. The next day have speech as well as physical therapy. So they have to be able to participate twice a day. They cannot be over fatigued by the process of rehabilitation. The goals for measurable improvement have to be achievable. The sickest patients are not the ones who end up staying in the hospital for acute inpatient rehabilitation. Interdisciplinary teams will manage the case. The medical team will have a very close affiliation with the rehabilitation team, and the surgical team should have that well established as well. Social workers will be very intimately involved from the first day of acute inpatient rehab in coordinating the services that that patient will need once they go home. The key to remember here is that the patients are motivated, they're physically strong enough, and they're able to participate at least for 2 sessions a day. The hospital surgical recovery will also sometimes be waylaid when there are other complications. As mentioned before, they will meet the criteria for restorative rehabilitation in the hospital, but often for these patients, recurrent hospital-based procedures may be necessary. For instance, a patient who has a biliary drain may be going for recurrent interventional radiology procedures intertwined with their physical therapy. So those are the types of patients who you may see staying in the hospital. There's also a short interval for further diagnosis and treatment. So a patient who is receiving chemotherapy or immunotherapy while doing physical therapy may be a good candidate for hospital-based rehab. Also, patients will sometimes need to stay in the hospital because their discharge home is unsafe, and they may not have insurance that would cover them to have care in a nursing home. Nursing homes in general are not going to take the uninsured. So if the patient has no insurance and they are an unsafe discharge and they have nowhere to go, there is no one to help to care for them at home, these are patients who tend to have very extended lengths of stay in the hospital, and the rehab will then occur in the hospital. So there may be some medical reasons why they will stay in the hospital. They have to be highly motivated, and sometimes the social service structure or fabric is not sustainable for them as outpatients, and that's another reason why they may stay in the hospital. Recovery at home really has several important cornerstones for success, and the most important thing here is really good pre-planning. From the time the patient is on their first day in the hospital, the plans by the multidisciplinary team have to be, how is the patient going to get home? So if they're having surgery, and let's take the example of a total hip replacement. In order to rehabilitate at home, certain important things need to be coordinated. First off, coordination for receiving durable medical equipment and supplies. If there are hospital beds that are necessary, that needs to be ordered very early on. How to get the patient walkers, canes, travel wheelchairs. This is all very important, and all this work needs to be done during the hospitalization. Then there's going to be coordination with a CHA or a community health agency. These are typically your visiting nurse programs. It could be VNS, VNA, Northwell Home Care. And these programs will coordinate the nursing component in the home, and that nursing component triggers the physical therapy, occupational therapy, and speech therapy that may be needed in the home as well. Also, it's very important for the social worker to work with the patient to identify that person who's going to be responsible for supervision of the patient, scheduling outpatient surgical follow-up, and being sure that the patient is prepared to receive people in the home, nurses, phlebotomists, physical therapists, etc. And then speaking of the home, there's the environment of care. For your patient who's having a joint replacement, it is hopeful that by the time they leave the hospital, they've at least been able to demonstrate that they can climb a few stairs, especially if they have stairs in the home. The ambulance may be able to bring them home and deliver them to a specific floor in the home, but their home environment may take some pre-planning. For instance, where is the patient going to live during the early phase of their rehabilitation? If the downstairs main floor has a kitchen, has a dining or living room big enough to be able to accommodate a temporary bed, and there's a bathroom all on the same floor, it may be wise to avoid going up and down the stairs in the beginning and rehabilitate from one floor in the home. If the patient lives in an apartment complex, you want to be sure that there is a working elevator. There are some environments that need to be modified with external ramps or even internal chairlifts. All of this work should be initiated from the time that the patient is in the hospital and not be thought about on the last day of discharge. This is particularly important in complex, long-standing cases in the hospital, where it's predictable that ramps and lifts would be necessary to be installed so that the discharge to home would be safe. So as soon as it's clear that that kind of equipment is going to be needed, the social service team needs to work on that. So it's a very coordinated, multidisciplinary approach, but pre-planning here is the key to success. Now, if that is not working, then skilled nursing facility criteria for rehab has to be considered. Now, this is done when there are no acute hospital care needs, but the patient has a rather intense and complex post-operative need that makes recovery at a facility much more practical than attempting care at home. For instance, there may be intravenous medications that have to be administered, and no one at home is skilled enough to be able to coordinate that. There may be frequent wound changes. There may be a significant lack of health literacy on the part of the patient and the family, where it's much safer for them to be in a skilled nursing facility. And most importantly, in the surgical rehabilitation phase, physical therapy and occupational therapy on a more steady basis than is available at home can be made available in the nursing facility. In general, in skilled nursing facilities, patients are able to participate at least once a day in therapy. Note that these patients who are not staying in the hospital for rehab are much sicker. You'll see patients with much more brittle comorbidities, such as congestive heart failure and COPD, the utilization of oxygen, the need for more complex wound rehabilitation with wound vacs, et cetera. These are the patients who are going to be in the skilled nursing facility. Those who are very frail and cannot manage 3 hours of rehab a day, they're weaker, they're sicker, and they're in the nursing home. So, limitations to perform the rigors of a hospital-based rehab may be based on comorbidities like infectious disease, heart failure, COPD, complex wound management. And then the geriatric 3Ds of dementia, delirium, and depression may present a mental status that would not work well for hospital-based rehab. And those with chronic mental illness may best be served in an environment that moves slower than an acute care facility. And finally, from the social service perspective, the unsafe discharge, those who are socially isolated, and those with difficult environments of care may also need to go to the nursing home. Emergent surgery, unfortunately, may unmask patients who are on the brink of falling apart in the community. Any experienced geriatrician sees this all of the time. For instance, hip fractures can often unmask a patient who's sarcopenic and falling and not really safe at home anymore. Those with chronic psychiatric problems, such as personality disorders, and those exhibiting behaviors such as hoarding, if that's complicated by recent cognitive impairment, that complexity is very challenging to discharge back home. Often the families do not want to be involved or responsible for individuals who are living alone with these types of problems. And a transition in a skilled nursing facility helps sometimes to stabilize these situations, especially nursing homes that have good psychiatry as a consultant service there. Other unmasked challenges are those who previously were unrecognized for their social isolation. I'm noticing increasingly that in my ambulatory practice, patients will present and tell me their concerns about being somewhat socially isolated, being the last of their family to survive. They no longer have siblings, those who have no children, those who have no nieces or nephews, those because of behaviors have isolated themselves from family and friends. They are very, very at risk for falling through the cracks, and only when there's an emergency does their dependent needs become unmasked. Also, poverty is a major complication that affects post-surgical discharge. There are in middle-class families in New York City, many people who may own a home but have no cash. So they are living week to week on Social Security. The money may not be enough. They sometimes have to, ask for help from other family members, but they do own a home. And this poses a unique problem when trying to apply for Medicaid services. And then there may be those who have been suffering physical, mental, or financial abuse. In my experience as a geriatrician, the greatest abuse is financial. I rarely see ongoing physical abuse of older persons, except in the case of aging husband and wife, where that has been a chronic pattern. And there may be some mental abuse that occurs, but financial is much greater. I see children and grandchildren taking advantage of parents and grandparents. Having the Social Security checks help to fund families and their meals. Also, the fact that the senior may have a home. Unfortunately, I see countless episodes or situations where a child may move in with their family and dislocate the older person to a single small bedroom in the basement. And they're thus very isolated, living in the basement when the home is in fact theirs. So unmasking these problems will often bring patients, unfortunately, into nursing home environments because they can't go directly home. Just a few topics here about some of the comorbidities. Infectious comorbidity, COVID significantly affected the landscape of nursing homes. For those of you who work in nursing homes, you're all well aware of this. Of course, legislative mandates affected admissions throughout 2020. You could, you couldn't, then you could again admit patients with COVID. The challenges that it presented to the nursing homes have been significant. The ability to isolate patients was very challenging, I think, in the beginning. Bed capacity was affected, occupancy rates fell. In the beginning, the cost of testing was prohibitive and was bankrupting a significant number of nursing homes. Staffing was very adversely affected as nurses and patient care assistants left the field. And nursing homes have not been able to compete with hospital systems to replace nurses and patient care assistants. They pay better, generally have better benefits. And so there has been a real dearth of people going into nursing and patient care directly into the nursing home. This is a significant economic crisis that is very widespread now in geriatric care. Mandatory reporting of infectious rates has really added to administrative stress. The availability of medications and vaccines are much better now, but in the beginning, there were very desperate situations in early COVID, leading to public relations nightmares for nursing homes where patients were dying in very high numbers in the early course of the pandemic. Things have stabilized significantly now, but I think some of the war wounds, particularly the economic impact of COVID on nursing homes, has been significant, and staffing is and will continue to be, in the short term at least, a major challenge for nursing homes. Other infectious comorbidities that affect patients who may be leaving the hospital after surgery are complications of pneumonia, and that's a frequent cause of readmission back to the hospital. These patients require intensive monitoring, isolation, treatment, when stable, prophylaxis with appropriate immunizations. Most nursing homes now have intact sepsis protocols so that everyone can work to the top of a license. And as soon as there's a fever or evidence of leukocytosis, a sepsis protocol can be triggered, which will allow for immediate intravenous fluids, intravenous antibiotics such as vanco and cefepime, and also the testing with chest x-rays, urine analysis, and labs, all to stabilize patients who may be on the brink of sepsis and try to prevent visits to the emergency room. C. difficile has mandated reporting of cases to the New York State Department of Health. These cases require a lot of staff time, increased housekeeping needs, isolation, treatment, tracking outbreaks, all very important from the nursing home perspective, and certainly makes for more complicated cases when patients are sent from the hospital with C. diff as a complication, particularly post-operatively. And then Candida auris is now a citywide challenge in terms of working to maintain and contain this infection. Local health departments may be looking to cohort at specific nursing homes these cases when they come out of hospitals. And this may be a problem that will be even more difficult to manage in the future. Other medical comorbidities that trigger skilled nursing facility are patients who have cardiac disease, underlying acute on chronic congestive heart failure, brittle AFib with variable ventricular rates, are also patients who tend to be more frail and require greater amounts of time in rehabilitation. COPD patients who have exertional hypoxia pose a particular challenge for postoperative rehabilitation and are usually best served in a skilled nursing facility where tracking oxygen needs can be very tightly managed, and patients can be monitored while they're exerting themselves for either hypoxia or symptoms of dyspnea. And diabetics also pose unique challenges in the postoperative arena. There may be certain nuances of medical management that are required in order to keep patients normal glycemic, and complications can occur with neuropathies, ulcers, and poor wound healing that require day-to-day monitoring of the patient. Now, there are specific geriatric syndromes that affect the disposition of patients. These include the 3 Ds of dementia, delirium, and depression, and then protein, calorie, malnutrition, and sarcopenia. So dementia, I don't want to go into this in great detail. You're all very well versed with this. Just remembering for the residents that the screening tests are screens, they're not diagnostic. And I really don't like to make this diagnosis the first time in the hospital setting. We're not giving a patient an optimal environment in which to be evaluated. But you should be aware that patients who are presenting confused for the first time, if you scratch the surface in conversing with family, you'll see that there may certainly have been mild cognitive impairment already present. Recognize this diagnosis as being a marker for very poor surgical outcomes. When the patients have dementia, they statistically do poorly and have higher rates of increased length of stay and poor outcomes. The worst, of course, is delirium. Metabolic encephalopathies complicating the postoperative state really are independent markers for increased length of stay, for increased all-cause mortality, and for significant functional decline. So it's got to be recognized. Triggers include the frequent change of location for the patient who has fallen and broken a hip. They are in an ambulance, they go to the emergency room. From the emergency room, they're probably in an area where they're being held before surgery. They go to the OR, they go to recovery. If there's a complication, they're in the ICU, then they go to a med-surg floor, then they're in sometimes heading to a nursing home. They could have landed in 5 or 6 different places in 72 hours. It's very disorienting for patients, and particularly for those with underlying dementia and cognitive impairment. So this is a very big challenge. The surgery itself can trigger delirium, the use of anesthesia, the amount of time under anesthesia, the polypharmacy risk of being in the hospital, and inadequate pain control are all situations that can increase the risk for delirium for patients. Post-operatively, these patients really never stay in the hospital, and they almost never go home. They are hard to manage. Families are a bit frightened by the delirious behavior of the patient. The hospital feels that it's an inappropriate environment because it's distracting. And so these are patients who end up in the nursing home. Just as an aside, to decrease delirium risk in the hospital, if you have a perioperative patient, make sure that we don't strip them of their sensorium and their ability to see, to hear, to taste. Keep glasses with the patient, keep the hearing aids with the patient, keep dentures with the patient. Often the families take all of these things for fear of losing them. And then we have a highly dependent, sick person in the hospital who can't see, who can't hear, who can't eat. It's really not optimal. We want to keep lights out at night and encourage sleep. There are certain programs now to really try to avoid phlebotomy rounds at 4 o'clock in the morning. And any disruption to a patient's sleep by staff should try to be avoided. And we also monitor for dehydration. Dehydration is an independent risk for the development of delirium. And it's very helpful to have a person who can easily orient the patient to their surroundings at the patient's bedside at all time. 1 or 2 family members can maybe take turns around the clock, but the reorientation of the patient by a familiar face is so helpful. So there's a tremendous benefit to expanded visiting hours or having 24/7 hours. I think that when this has been instituted, it's worked very well. There were some concerns about staff being overwhelmed by demanding patient family members, but the family members can really act as very good advocates. And at a time where bedside care is challenging because of staffing issues, it can be very helpful to have somebody there to help a loved one. So these 6 factors are very important to decrease delirium risk. And the diagnosis of delirium is done by the old nursing confusion assessment method, where acute onset of change in mental status and inattention are both present, and either disorganized thinking or altered level of consciousness has to also be present. This is a subject for an entire other lecture. I just wanted to mention it. And then the Geri syndrome of depression is also an independent marker for poor surgical outcomes. This increases risk for all-cause mortality when a depressed person is hospitalized. It increases their risk for delirium. It's associated with much more prolonged rehabilitation. And these patients, unfortunately, are at much higher risk for not achieving postoperative goals. It often worsens after hospitalization, so it's not uncommon to see depression increase when patients are back home or when they're in a skilled nursing facility. And the risk for polypharmacy complications, especially when there's heavy use of pain medication, is another present factor. Protein caloric malnutrition can really lead to that frailty syndrome that we were mentioning earlier. Patients who lose 10 to 20% of their total body weight may exhibit constipation, exhaustion, significant loss of both fat and muscle, and they do not seem to have the energy to perform high energy tasks. Their grip is weakened, their heart rate may be slower. So if one has muscle wasting, loss of subcutaneous fat, a nutritional intake of less than 50% of what is recommended for at least 2 weeks, or they've become bedridden with a significant decrease in functional capacity, these are patients who have protein calorie malnutrition. And from the time they're in the hospital, immediately this needs to be addressed because their post-operative outcome will be poor. These patients need to be differentiated from those who are suffering from hypothyroidism, particularly, and anemia. And these malnutrition syndromes are associated with chronic diseases such as malignancies, chronic alcoholism, liver disease, end-stage renal, drug abuse, poverty, anorexia. The list can go on and on. It's got to be identified. It's a major contributor to frailty. Also contributing to frailty is the natural syndrome of sarcopenia. This is an age-related involuntary loss of skeletal muscle mass and strength. And when I tell residents that sarcopenia starts when they're in their 30s, they're usually rather surprised at that. But it continues in a linear fashion with a loss of 50% of total mass by the 8th decade. It's part of the aging process. Because of decreased muscle mass and strength, we can have increased risk for falls, slower walking speeds, muscle wasting. And the good news is that with resistance and strength training, this can be turned around. So this is an aging progression that can be reversed with motivated exercise and with potential increased lifespan and improved quality of life. So persons who do not address this with regular exercise are at increased risk for sarcopenia in older age. Let's talk for a few minutes now about the economics of skilled nursing facility care. Medicare Part A covers the hospital and the skilled nursing facility for rehab. There is a defined Medicare benefit period, or MBP. It starts on the first day of the hospitalization, will continue through the skilled nursing facility stay, and extend to 60 days after final discharge. There's only one deductible for that entire Medicare benefit period. So if the patient has a very long hospital stay, there's one deductible that will cover the first 60 days. And then that will not be repeated if they go to a skilled nursing facility. There is, however, coinsurance mandates that kick in on day 60 of $389, and at day 90, that goes up to $778 of coinsurance for what's called a lifetime reserve day. And these are days at this very extended length of stay, and there's a maximum of 60 such days in your life. Now, once a person enters a nursing home, the Medicare Part A rules are fairly simple. They will cover 100% of costs on days 1 through 20. The coinsurance then is 0. Days 21 to 100, the charge is $194 a day. And after that, after day 100, there is no coverage. It's amazing how with this financial incentive, most patients will leave a skilled nursing facility within 3 weeks. Now, in the nursing home, Medicare will cover all physical, occupational, and speech therapy, will provide for semi-private rooms, meals, all the nursing services, prescription drugs, and covered immunizations. And sometimes there are gaps in immunizations that can be caught up with during skilled nursing facility stays. It will cover medical supplies. It does not cover private duty nursing, the use of telephones, TVs, any personal items, or private rooms, unless a private room is mandatory for their medical needs, such as COVID isolation or isolation for C. diff. Medicare Part B will cover all of the physician services in the skilled nursing facility, just as physicians get paid through Part B when they go into the hospital and also when they see patients in ambulatory care. I was just mentioning immunizations because there's a big push to have patients catch up with immunizations when they're in skilled nursing facilities. In my nursing home, we are now looking to start immunizing with Tdap. for those who may be behind, offering Prevnar 20, also for patients where it's not clear what their pneumococcal immunization status is. We do look at CIR to see if they have any information on their New York City registry for what may be necessary. Also, nursing homes have a very big push for annual influenza vaccination, and now also the bivalent COVID vaccines are available and distributed in all skilled nursing facilities. So Medicare Part C, for the residents and fellows who may not know, it's the Medicare Advantage plan, which is sponsored by private insurance. Each of these insurances may have different deductibles and copay structures. The coverage for a nursing home will be for short-term rehab and long-term care. And it's been established by very specific industry guidelines. The old Millman and Roberts criteria, now called MCG, or interqual criteria, may be applied here by the insurance company to establish coverage rules. There are some specific nursing home products that insurance companies may develop, such as United Healthcare having their Optum plan. And in Optum, very interestingly, they will, based on the volume of patients who choose this option in long-term care, the insurance company will put skilled nursing nurse practitioners, place them in the nursing home so that they are there for those patients to evaluate them when physicians are not. So their theory is that they are there to provide care when there's a change in status, if there's an acute care need, if there's an accident of any kind, and they can intervene right away. They provide 24/7 coverage to the nursing homes with backup nurses to evaluate patients as well. Interestingly, Medicare Part C in April of last year represented 29 million Medicare beneficiaries, and this number is growing every year. The Center for Medicare and Medicaid Services, CMS, has certain quality measures that are published for nursing homes, and they base it on review of insurance data. Now, the Medicare Part C plans their quality numbers are based on the aggregate of the plan rather than looking at individual cases, whereas when you break down to individual nursing homes who have straight Medicare, you can get a much better refined number for the care received at that particular nursing home. So some of their quality measures can be a bit misleading. And we're going to talk a little bit about comparing nursing homes and how to evaluate some of those CMS markers. Now, Medicaid for restorative rehabilitation is also available in skilled nursing facilities. Each state will define its own criteria, and each nursing home has to be certified by its state survey agency as a Medicaid nursing facility. One of the markers of being a Medicaid facility is that each person's plan of care has to be individualized for them. So each care plan is unique. You cannot have a rubber stamped care plan for all patients who enter to have the same rehabilitative treatment plan. Federal law mandates under Medicaid that there's coverage for nursing, for rehabilitation, for medical needs, for pharmacy, dietary services, professionally directed activity programs, emergency dental and routine dental services, and room and bed maintenance, and routine personal hygiene items and services. So if you are a Medicaid nursing facility, you have to offer all of these things. What's in the law really drives provision of the service. So that's why there are dental programs in each nursing home, and also why there are rather robust recreation programs, which include socialization events, certain celebrations, birthday parties, entertainment, art programs, and music programs. All of this is coordinated through a licensed recreation coordinator, and the programs are available to all in the nursing home. Now, if a person has both Medicare and Medicaid, they are then referred to as being dually eligible. And in New York State, a managed long-term care, MLTC, is the mandatory vehicle for those who are dually eligible, over the age of 21 and in need of community-based long-term care services for at least 120 days. So MLTCs may cover patients who are not geriatric, but they may cover those who have Social Security, disability, Medicare, and Medicaid, who because of accidents are bedbound. And there are many other medical illnesses also that can bring patients to MLTCs. They cover skilled nursing facility services as well as home care, adult day health care, home delivered meals, medical equipment, podiatry, audiology, and also physical, occupational, and speech therapies. There are other payment options for nursing home. There are third-party insurance plans, so private insurance that may be obtained by persons who are working after the age of 65. They may have independent Aetna or United Healthcare or GHI plans. And the skilled nursing facility coverage may be very variable based on the plan that they have through work. Private pay is an option for a very small percentage of patients, but there are some families who will pay the bill entirely. Either the individual patient will pay or their family. Patients who are on hospice programs will have certain things covered by Medicare Part A, but the room and board in a skilled nursing facility still has to be borne privately by the family. And then there's respite care, which is another type of care provided in nursing homes, where families are able to go away when they normally care for someone at home. If they go away on a vacation and they need someone to provide care, they can go to a nursing home and they'll often be charged the Medicaid rate for private pay for respite care. Now, the social service reasons for skilled nursing facility is that the cornerstones of success at home failed. Again, the pre-planning may have been great, but perhaps the child did not accept the case, or there's nobody who is willing to accept the responsibility for supervising the patient at home, and it's thus seemed an unsafe discharge, or the environment of care is poor, meaning that it is unsafe. So the durable medical equipment may not be manageable at home, like a wound vac that families cannot handle, or that the patient is alone for a lot of the day and is not able to manage the wound vac. Sometimes the community health agency will not accept a case. This historically will happen with patients and families that have been known to be difficult to manage during previous admissions, or it may be an unsafe situation for an unsupervised patient. There may be a lack of a responsible party to supervise a dependent patient. Again, the socially isolated, those with no family, those who have no willing volunteer, who have high medical needs. And some of those cases do need to be referred to adult protective services upon discharge from the nursing home. And then the environment care, as I had mentioned earlier, building wheelchair ramps and chair lifts in the home. One may need time for that. There has to be a safe way to enter and exit the home. Sometimes there are behaviors like hoarding, which make it impossible for people to come into the home to care for the patient, such as physical therapists or visiting nurses, because the hoarding is so terrible. So that may also be a reason why a person would not be able to go home. Poverty leading to impoverished homes is really not a barrier to home care, except in cases of lack of power, animal infestation, and when there are entrance and egress issues, which challenge safety for the patient and for those caring for them. So how do you choose the right nursing home? Sometimes comorbidities really direct the care. There may be a specific certificate of need that's obtained by individual nursing homes to address these needs. Respiratory care for mechanical ventilation. So one nursing home may have a vent unit and they've gotten a certificate of need for that, and they invest a lot in providing that care. Other nursing homes may build their own hemodialysis units, or there may be allowances for bedside dialysis, as occurs at the nursing home where I'm medical director. There may be a traumatic brain injury unit where patients are managed specifically to recover from TBIs that may be related to stroke or car accidents or falls and injuries. And then there can be formal dementia units that also are certified by a certificate of need. Sometimes also a nursing home will develop a niche in a community where they may not have a specific certificate of need for a particular service, but because they manage so many patients with a particular problem, they develop sort of unofficial expertise. That may happen based on geography. If a nursing home is in a community where there may be more HIV, and as HIV communities age, this is an increasing need for skilled nursing facilities. So how do you compare the nursing homes? Well, you can go to Medicare.gov, where you can see comparisons of quality measures that include staffing, health inspections, and other specific quality measures. And there are also CMS forms, number 2567 can be found on Medicare.gov, which will address survey findings. So when a nursing home's undergone survey, the findings are posted for the public. Long-term care ombudsman resolves individual patient complaints, and they also advocate for quality of life issues and for improved resident care. And by contacting the ombudsman, you may get information about local nursing homes. And the New York State Department of Health has really got a lot of information on their website. New York State Health Profiles is the specific site that will compare quality of care, quality of life, and safety for nursing homes. And Health Data New York also tracks markers such as successful discharge to the community. In New York State, as of 2 years ago, the average return to prior residence from short-term restorative rehab was 57%. It also will publish data on pressure injury rates and the use of psychotropic meds. And these are all markers that one may want to take into consideration in deciding which nursing home a patient should go to. There is a specific skilled nursing facility application process in New York, and this is pretty much done through the Hospital and Community Patient Review Instrument, or PRI. The PRI pulls together the demographics of the patient, all of their medical diagnoses, their prognosis, their behaviors, their therapy needs, their specific treatments, medication, and also the use of DME, and also ADL scores of bathing, dressing, toileting, mobility and transfers, and eating. So a nursing home gets an idea of how functional a patient is by reviewing the PRI, and therefore guesstimating how successful this patient is going to be in short-term restorative rehabilitation. So rehab in the nursing home is a physician-led individualized treatment plan with a multidisciplinary team of the nurses, the social workers, the rehab specialists, dietitians, and recreational team members. All receive opportunities for physical, occupational, and when needed, speech therapy. Often consultant psychiatry, dental, and podiatry services are available right there in the nursing home. Most nursing homes can provide patients with intravenous fluids if necessary, intravenous antibiotics. There are wound care teams and consultants, credentialing of specialists for follow-up care, and lab services, basic radiology, ultrasound, and echo. Interestingly, there are barriers to subspecialty surgical follow-up at a nursing home. Now, one of the first barriers is the patient themselves. The patient or the family may feel too overwhelmed after a hospitalization, and they want to postpone leaving the nursing home for a consult until the patient's feeling stronger. So although the hospital may recommend surgical follow-up in the clinic 3 days after discharge, that may not be happening for another 3 weeks. There are insurance barriers. Authorization for certain specialty appointments requires a process. And in general, the managed care facilitators in a nursing home are not as savvy as those in the hospital, and they often are providing multiple functions. So staff limitations is a barrier in getting all of these insurance authorizations done in a timely fashion. There may be a medical barrier, such as complications of sepsis and delirium, which makes it difficult to have the patient leave the nursing home to go see a surgeon for follow-up. Financial barriers also exist. Ambulant transport is not covered by insurance if a patient is in a nursing home. So since you can't use the ambulette, well, you could, but it'll cost you probably about $400 is the going rate for where I am right now. And so for a lot of families, they don't want to pay that, and they have to agree to that up front. And then there are specialty barriers where the specialist themselves does not have enough openings in their schedule for timely follow-up. And increasingly, especially since COVID, specialists are not going to the nursing homes. So what then becomes the key for success? Between the hospital and the nursing home, there has to be really specific bidirectional communication. And that has to happen, in my mind, it's best served physician to physician, so that nuances of care that are often missed in hospital discharge paperwork can be clearly established when one doctor speaks to the other. But as we all know, that is sometimes easier said than done. Direct
Donna?
surgical follow-up. Yes?
Donna, speaking of
Yes.
one doctor speaking to another, I just want to give you a 3-minute time check.
Sure. Okay. Direct surgical follow-up has to be established at the time of discharge. Specifics for wound care has to be also done as well. Sepsis protocols, delirium management, and the management of vascular complications is also imperative in tight management of post-operative patients. Now, orthopedic cases have really sort of dried up for going to nursing homes compared to the rates at which they went before COVID. Rehabbing at home for joint replacements has become much more the standard of care now. But sometimes they have to go to a nursing home because they are not able to go directly home because home is not safe. It's also noted that there are really excellent outcomes when hospital surgical teams, particularly orthopedic teams, are embedded in the nursing home. They go to the nursing home to see patients. There is a lot of care that can be provided when you are seeing everybody all at the same time, and that works out really well. The cardiac patients also tight bidirectional follow-up with very specific guidelines on what to do for the cardiac surgery patient is imperative. Aortic stenosis is being seen increasingly for patients who have surgical or transcatheter aortic valve replacements. They do very well in the nursing home when there are specific titratable goals, especially related to complications of congestive heart failure. And again, that bidirectional communication is key. There are a lot of urology issues relating to difficulties in nursing home care. Patients who spend a lot of time under anesthesia will often be sent to a nursing home with a Foley catheter, yet Foley catheter management, bladder retraining is not necessarily well documented upon discharge. And so individual nursing homes need to establish really good communication with their local urology departments. Same thing with wound management. Many surgeons like to manage their own wounds, and this is another issue that will sometimes cause delay if there's difficulty in getting the patient back to the surgeon. Good nursing homes will have a dedicated wound nurse who looks at all of the wounds, is responsible for day-to-day management, and having he or she directly work with the PCP in the nursing home and the surgical team really will work well. Sometimes the cost of dressings can be prohibitive. I personally love silver-based dressings for necrotic wounds, but they are expensive. And increasingly, post-trauma patients who go to a nursing home, I think they have some of the most difficult times because you really need creative solutions for the costs of intravenous antibiotics and TPN. And trauma teams often sign off the case once the patient's discharged. And that can be another, challenge. Lastly, telehealth. You know, COVID really provided the perfect trifecta of regulatory relief, expansion of coverage for telehealth codes, and the medical trigger to have the insurance industry and medical systems really embrace telehealth in a way that it never had before. And as specialists are withdrawing from care at the nursing home, telehealth has really become very important in ongoing psychiatric care, orthopedics, rheumatology, neurology, and infectious disease. But the use of peripherals, particularly the use of stethoscopes, really allows for very unique abilities of pulmonologists and cardiologists to be able to evaluate patients remotely. And this may really be the future of almost all subspecialty care in the nursing home. So successful postoperative care is essential to have bidirectional communication, very specific goals and targets for treatment, very carefully communicated from doctor to doctor and laid out so that it's understood for individual and specific treatment plans. And then surgical team access by physically following up in person or via telehealth is also essential. And those appointments should be made from the point of discharge for patients from the hospital into the nursing home. So I hope that this sort of quick overview of how to triage patients and recognizing some of the risks that geriatric postoperative patients face and to see the complexities of nursing home care has given you a mechanism by which you can try to choose the best nursing home for the postoperative care for all of your patients. And I thank you very much for the attention that you've given me here tonight. Thank you. I can't hear you, Paula.
Oh. I got unmuted twice. Sorry.
There you are.
Thank you so much, Dr. Seminara. That was fantastic, very informative. Amanda put the link in through the chat for to get CME for those of you who get CME. Again, please check out NYACP if you're not already a member. Check out NIMDA if you're not already a member. I have a question, but Meryl, if you had a question, you can go first. Okay. So my question is, my experience has been, since COVID, that the patients who come to the nursing home for rehabs are like way sicker than ever before. And I think the people who are, just trying to avoid facilities as much as they can, are you seeing that too? And do you think that's going to last?
100% we're seeing that. So the easier cases, the orthopedic cases, they absolutely left. And even some of the more complex postoperative cases have been trying to rehab at home because of the family's fears of infectious complications going into a skilled nursing facility. So that's definitely true. We're also seeing a lot more geriatric comorbidity with dementia and delirium in the nursing home. So these patients are much more difficult to manage, I think, from a neurologic and emotional perspective. So we're definitely seeing that. We had also a lot of complications of COVID, patients who were coming and who we were holding for isolation and then retesting. They would then, on day 5 or 8, test positive for COVID, even though they didn't have COVID as a discharge diagnosis. And then that sort of blows up the plan a bit in terms of rehab. So rehab gets a little slowed, doesn't stop. And thank goodness with the current variant, although it seems to be highly infectious, it doesn't seem to cause the degree of comorbidity, certainly, that we had seen 2 years ago, when it was frankly a very challenging and frightening time to be in the nursing home industry. And I just have to say, the physicians who I've seen at other nursing homes and in my own nursing home, I mean, doctors really stepped up. They were there, they were fearless, they were brave, and they got sick. And sometimes they died. People really were very brave in the face of COVID. So I will never forget that as a very unique time to be a medical director of a nursing home. It was challenging in ways that I never expected in that role. All of that said, yes, since COVID, the landscape for rehabilitation in nursing homes has changed. I think that nursing homes have gotten much better at identification, isolation of patients, testing. Of course, now at least we have everything. May 11th, we may find that the pandemic is officially over, and what that means for the emergency use authorization of a lot of the things that we have in our armamentarium for COVID, that may change. So there are a lot of interesting things, I think, still to come. So that's sort of a long-winded response that yes, it's different, and I don't know when it's going to change.
I guess it's good that it's not just me.
No.
We have a question that came through the chat. It says, a lot of orthopedists seem to have their own protocol for DVT prophylaxis. Do you have a preferred recommendation or a regimen?
So this is a challenge, especially if you are in conflict, with the orthopod. I find in general lately, the orthopedic cases that are coming to the nursing home are more complex. You're not going to find your simple ones there. And a lot of them have a lot of cardiac disease that actually mandates systemic anticoagulation. We do defer and allow for the individual surgeons to prescribe what they, the prophylaxis that they prefer. And almost all of them, I see, really sort of cutting back on long-term anticoagulation. They really want them mobilized and moving. Everyone should recognize also that we can do very quick diagnostics if we do suspect some sort of thrombotic event. So we're seeing patients actually staying on systemic anticoagulation less and less, whichever you personally prefer. We also, because of their frailty, see bleeding issues. I have had situations where the systemic anticoagulation, results in, major bleeds, especially in those at risk to fall. So the nursing home environment is a tough one in terms of that particular issue. We don't have a policy of mandating what it is. We do sort of give latitude to the surgeon. But if we're seeing bleeding problems, et cetera, we step in and we stop.
Makes sense. It's like, all the geriatrics, personalized, patient-centered, factoring 1,000 comorbidities and risks and benefits.
Yeah, exactly. I also sort of get a kick out of the doctors. I have to undress it first. I have to undress the wound first. Well, if you're not making yourself available to undress the wound and it's getting fetid looking, I'm sorry, that dressing has to be changed. And we're happy to utilize telehealth and while we still can, even utilize, setting up a Zoom or a FaceTime with their PA or, something. We'll take pictures and we'll send it to you. I have found that the use of telehealth also really cuts down on some backstabbing that can occur. Oh, this happened because the patient was in the nursing home. I had a patient who was orthopedic who was having complications of a surgical wound. And I said, when you're there, I said to the family, can you turn on your phone and just hand it to the doctor and I'll be right here. And and all of a sudden, miraculously, it's not as bad as I thought. And, everything really changed. So I think there's a lot of advantage to the telehealth realm in post-operative nursing home care, for sure.
That's what my big line, COVID sucked overall, like clearly no question. But I say two good things came out of it. One, I get to wear scrubs to work again, and two, Zoom. So I think hopefully we could keep the good and get rid of the bad.
Yes, absolutely. Absolutely. I think, the opening of telehealth has really been tremendous for improved coordination of care. Something that we're trying to do now also is set up a specific plan where I've got me in the nursing home embedded in the nursing home chart, and concomitantly a geriatrician in the hospital looking at the hospital record. When I have a patient who goes back to the hospital, I can give them information and I want to hear what's happening there, so I know what to do when the patient comes back. So we were just looking at a case today of a woman who was very hypoxic post-COVID, ironically, who had to go back to the hospital for progressive hypoxia, very high D dimers, LDH, everything. She really requires still hospital level care. And then we were looking at the record, she's got non-Hodgkin's lymphoma. Okay. When was this treated? All of a sudden we were concerned, are we looking at actually a complication of her lymphoma? So, we were able to get the appropriate consultants right away. And the question can be asked and answered because you have two people looking in the records on the continuity of care of the patient. and not letting things, fall through the cracks. Whereas, she could come back to the nursing home, still not getting better. Oh, that wasn't addressed. Now I've got to find her a local oncologist who's willing to take the case. Anyone knows from an outpatient perspective, that's a tough thing to hoist, right? Whereas in the hospital, I can get it done much faster and come back to the nursing home with a lot more information. So
That's great.
just
Yeah, the
thinking of
EHR
some
is
new
a
ways
lot
to address the problem. Yeah.
and like Donna said, thanks everyone for all the important work that you do.
Thank you, everybody. Appreciate it.